With the development of the COMPASS program, we have examined many resources and have made recommendations for implementing assessments of physical and cognitive function. We've listed several commonly used functional assessment tools in our therapy toolkit, which can be found within our hospitals and providers section of the COMPASS website. While no one tool will be best for every patient, it's important to choose tools that will be best able to measure improvement of your client's specific stroke impairments. Consistent use of functional assessment tools helps quantify goal setting and progress towards goals. Use of tools such as the Short Physical Performance Battery and gait speed can help therapists make decisions about when a patient is safe to transition either from home health to outpatient or from outpatient to a more independent community-based program. You may receive copies of physical and occupational therapy evaluations from your referring acute care setting. For example, patients coming from Wake Forest Baptist Health should already have had some baseline assessment scores. For PT, you would commonly see scores for SPPB, gait speed, and a modified Rankin score of global stroke disability. For OT, you would commonly see a MoCA score for cognitive screening and a short Fugel-Meyer score indicating motor function impairment. You may choose to continue with these assessment tools in setting your own goals, or you may choose tools that you feel are more appropriate for your patients as they progress through the home health or outpatient setting. When choosing functional assessment tools, you need to consider what will best capture change in your client's deficits, but also think about what will be a reasonably quick and reliable tool to use. As mentioned before, an SPPB can be completed in just a few minutes and gives you measurements of lower extremity strength, gait speed, and standing balance in your patient. You could also choose to use a 2 or 6 minute walk test to help measure improvement in your client's functional capacity over time. For cognition, the MoCA is a reasonably quick tool to assess for concern for cognitive impairment. The CATS ADL tool is a 6-question tool that assesses a patient's ability to perform 6 functional ADLs, including bathing, dressing, toileting, transferring, continence, and feeding. The scoring is a yes-no system and results in a score of up to 6. 6 indicates full function, 4 indicates moderate impairment, and 2 or less indicates severe impairment. Box and Blocks is a tool that can be used to assess gross manual dexterity of the upper extremity. These are just a few examples of functional assessment tools that are appropriate for use in this population. This slide is a summary of the therapy map that we want to follow in treating our COMPASS clients. Let's think back to the 4 domains of exercise that we need to be providing for our patients. Our goal is to always provide structured and progressive exercise routine within each domain, including muscle strengthening, balance and coordination, flexibility, and endurance. Utilizing approaches from evidence-based practices that we've presented, such as Otago, Life, and GRASP, you can create a tailored plan of care that meets your client's specific needs. For a patient who has PT and OT consults, PT may be focusing on using static and dynamic standing exercises like those found in Otago to aid in strengthening and balance work. PT should also focus on developing a cardiovascular program to improve the patient's functional capacity and quality of mobility. OT may be focusing on specific upper extremity deficits that require the consistent repetition of the GRASP program, as well as focusing on ADL function and safety and any cognitive issues that may be present. Our united goal for the patient is to keep challenging them and stretching them toward being more independent in their exercise programs and better able to self-manage their activity as well as their medical issues. A big piece of the comprehensive care plan presented in COMPASS is remembering that all of us as healthcare providers have an essential role in educating our clients. It's not just the job of the home health nurse to educate clients on things such as blood pressure management. Every clinician needs to be speaking a common language and reinforcing each client's individual care plan that you will receive with each COMPASS referral. Overwhelming evidence has indicated that regular physical activity is one of the most powerful health-promoting practices that physicians and other healthcare professionals can recommend for patients. In a recent call to action for the National Physical Activity Plan, the American Heart Association highlighted that a lack of physical activity represents a leading cause of death worldwide. As clinicians, we all have an opportunity to be more direct and consistent in counseling our patients on the importance of physical activity. It is important to remember that physical activity counseling is not just the role of PT. It belongs to the PCP, to the home health nurse, and to every health professional that the patient and caregiver encounter. The message can be as simple as this: regular physical activity is essential for optimizing recovery from stroke, and it's essential for helping prevent another cardiovascular event. There's compelling evidence from 2 landmark trials of how powerful healthcare messaging is. First, in the activity and counseling trial, PCPs were trained to deliver brief 3-minute interventions during routine office visits. These were associated with increased levels of physical activity over the 2-year follow-up period, as well as improvements in cardiorespiratory fitness. Most of the clinicians reported that counseling did not disrupt or increase the length of their visit, and that the counseling was an asset to their practice. Similarly, in the Premier trial, it provided strong evidence that brief lifestyle and physical activity counseling among adults with prehypertension or stage 1 hypertension resulted in significant reduction of cardiovascular risk. This was shown through a 12 to 14% relative reduction in the 10-year Framingham coronary heart disease risk score, which was maintained at 18 months post-study. It doesn't take much time to make an impact. Consistency of conversation across time and across providers should be that much more impactful. We need to start talking to our patients about physical activity with the same importance that we discuss routine vital signs. We know to counsel on blood pressure management, heart rate, cholesterol, glucose management. We need to make physical activity counseling a routine vital sign. We're encouraging everyone from the PCPs to community-based exercise providers to ask patients if they're getting regular exercise. If the answer is yes, then record the parameters of it, the mode, frequency, duration, and tolerance, the same way you'd record any other routine vital sign, and acknowledge the patient's good work. If the patient is not participating in any regular activity, engage them in a bit of motivational interviewing to find out why not and to assess the patient's willingness to become more active. Try to work together to identify an activity that the patient could safely and cost-effectively engage in that they would actually enjoy. We all need to consistently plant this seed towards getting our patients more physically active. We understand that many of our patients will not be able to come close to meeting the recommended guidelines for all Americans, which is to get 150 minutes per week of moderate intensity or 75 minutes per week of vigorous activity. But it's important to remind people to start slow and to progress. Research shows that as little as 10 minutes of continuous activity can be beneficial for people. As clinicians, we want to be counselors, but also cheerleaders for our patients in order to help them be successful. Our basic message really should be that recovery is a process that can take years, and the potential for gains do not cease as long as you continue to move and strive to increase your physical activity levels. We all need to remember this personally and to keep conveying this simple message to our clients. To summarize, we've created a checklist for our providers and our clients. We want every provider to counsel for physical activity and safe mobility. We want to counsel on that physical intervention must be structured and progressive. Physical intervention must include at least strength and balance components, and it must address upper extremity function and dexterity. We need not to forget to address fall prevention strategies, and we want to encourage safe mobility and self-management, leading patients to more independent lifestyles. Your client should be able to answer yes to each of these questions. Does the exercise program include exercises to improve my balance? Does it include exercises to strengthen my legs? Does it include exercises that start at a level I can safely do? Does it challenge me to try harder with progressively more difficult exercises? And does my healthcare provider ask about how much physical activity I do throughout the day? We realize that certain components may be stressed differently depending on the client's functional status and the specific areas that need improvement. But in reviewing your care plans for your patients, you need to make sure that you have included all of these areas. We've created a case scenario loosely based on a recent referral to the stroke service team at Wake Forest Health to help tie together everything we've been discussing. The patient that presented was a 67-year-old female who was admitted to an outside hospital with complaints of blurry vision, double vision, nausea, ataxia, and a headache for 2 days. Onset of symptoms was the evening prior at 9:30 p.m. The patient was transferred to Wake Forest Baptist for a stroke workup. Her past medical history was pertinent for diabetes with uncontrolled blood sugars, coronary artery disease, hypertension, and hyperlipidemia. Imaging at the outside hospital indicated acute infarcts in the right and left cerebellum, right greater than left, posterior right pons, left occipital, and posterior right parietal areas. On arrival, the patient's double vision had resolved and clumsiness with her right hand was improving. No TPA was administered as the patient was outside of the therapeutic window. The patient also had an evaluation by cardiothoracic surgery for her coronary artery disease, and it was determined that she would need to undergo bypass surgery after her initial recovery. Of note, the patient's risk stratification numbers have actually been improving over the last 2 years with management. However, her hemoglobin A1C remains high at 8, and her triglycerides remain mildly elevated. The PT assessment found that the patient scored 2 of 12 on the SPPB, which indicated a high fall risk, and had significantly impaired functional mobility currently. Her gait speed was only 0.26 meters per second, which is considered to be high fall risk and limited to household mobility safely. She also had significant deficits with her gait quality and required the use of a rolling walker with close supervision for gait safety. She scored 3 of 6 on the Rankin Stroke Scale, indicating moderate disability, and was only able to walk 200 meters with a 6-minute walk test, which is about 17% of predicted distance for a community-dwelling elder female of the same age. She continued to present with right-sided coordination and balance deficits and diplopia. PT recommended discharge home with 24-hour supervision and assist initially, and a home health PT referral. On occupational therapy assessment, the patient was found to have mild cognitive impairment, 22 out of 30 on the MoCA score, continued diplopia, and global coordination and sensory deficits, affecting her ability to safely complete her ADLs. OT recommended discharge home with 24-hour supervision and assist, use of an eye patch with specific wear instructions, and a home OT referral for ADLs, cognition, and visual issues. The patient had an acute referral by a speech-language pathologist for functional swallow evaluation as well as communication evaluation. She did not demonstrate any clinical signs of aspiration, and her cognitive linguistic evaluation was within normal limits. No further speech services were recommended. The patient's discharge summary indicated that the patient was being discharged on dual antiplatelet therapy for 3 months, Plavix and aspirin, and that she would be discharged home with 24-hour supervision and assist, and referrals for home health PT, OT, and nursing for further management. Within the COMPASS model, the patient would be referred for home health PT, OT, and nursing services per her needs profile. She would get an introduction to the COMPASS program in the hospital by the PAC, who will work with the case manager in the hospital to coordinate home health referrals to an agency who's agreed to provide the COMPASS care model for its patients. The PAC will call the patient 2 days post-discharge to assess for med issues, service referral issues, and to ensure that the patient has not had any concerning recurrence of stroke symptoms since discharge. Then the patient will be seen at 7 to 14 days post-discharge by the APP, who would be a neurologist or stroke nurse practitioner, to undergo a multidimensional needs screening and a full neurological evaluation. From this assessment, the patient's individualized care plan is developed and sent to the appropriate care providers, PCP, home health staff, or outpatient therapy staff. While home health or outpatient may have already evaluated the patient and set a plan of care, it's important to go over the individualized care plan with the patient and ensure that the patient-specific goals are being incorporated into the existing plan of care if services have already been initiated. For example, PT should be ensuring that the 4 domains of exercise are being addressed, as well as beginning education and counseling based on patient-specific needs. For this patient, this may include improving her understanding of how consistent exercise can improve her diabetes control and lower her A1C, in addition to improving her understanding of how exercise can help with blood pressure and how med management can help lower her recurrent risk of stroke. For the occupational therapist, the patient's plan may include safety with ADLs, as well as ensuring that cognitively and visually she can manage her med administration. She may be appropriate for education on activity pacing and stress management also. OT should also continue to monitor for changes in upper extremity dexterity and tone issues and incorporate the GRASP program if needed. Home health nursing will be similarly heavily engaged in patient education and behavioral counseling with regard to medicines, chronic disease management, stress management, smoking cessation, weight management, and ongoing vital sign monitoring. While home health nurses are already quite active in all of these areas, a focus on recording physical activity as the sixth vital sign will be key in helping patients make lasting behavioral changes. So in putting it all together, the ideal COMPASS progression would be that the patient improves significantly enough that all home health services would be able to be discharged within a reasonable time frame, and that the patient would be shepherded toward outpatient services as needed, in this case for further balancing and mobility training. Ultimately, the goal was that the patients would be transitioned to an independent exercise program in their homes or to appropriate community resources programs to sustain a healthy level of activity. While we understand that not all patients have appropriate funding sources to make this possible, we're seeking to maximize gains within the scope of their time with us and to help shift uninsured or underinsured patients towards less costly community resources as long as they are safe to participate at that level. Consistent follow-up with a nurse practitioner at the PCP office who will continually monitor health status and physical activity participation is essential to the patient's ongoing management. It's so important for us as providers to provide high-quality therapy for our clients while they're under our care. However, we have to always remember that it's just as important to help our clients find their way to the next stage of care, whether that's transitioning from home health to outpatient or from outpatient to community-based programs. The COMPASS website has a county-specific directory of community resources available under the Patients and Caregivers tabs that can help you quickly see what services are readily available in your area. This will be a living document that will be able to be updated to reflect accurate information. Community-based resources vary widely from place to place throughout North Carolina. Most programs that are available in the community are falls prevention programs or community exercise programs. One of the most essential parts of the COMPASS program is the Community Resource Directory, which is being developed to focus on what programs are available county to county throughout the state. It will be important for all clinicians to familiarize themselves with what services are available in your area to maximize how we can assist our patients. If you as a provider know of a resource that is not included on this list, please contact amullins@wakehealth.edu to provide information to have the resource added. Most of the links that will be helpful to providers are located on the COMPASS website under the Hospitals and Provider tab. Copies of the boot camp training materials are available, as well as other written tools for helping facilitate patient care. There will be a patient video posted that features moderately involved patient and a significantly involved patient participating in Otago balance and strengthening exercises and in some of the life-type activities. Finally, the toolkit is located here that has information regarding functional assessment tools, links to evidence-based practice interventions such as Otago, GRASP, and LIFE, and home safety and falls prevention tools. It will be helpful if you spend some time on the COMPASS website after you register to see what tools are available and think about how you can best incorporate them to enhance your practice. There are additional resources under the Patient and Caregiver tab, including the Community Resource Directory and links to sign up for the American Stroke Association Network. We're almost finished. We just want to leave you with a few last tips to help incorporate the COMPASS model into your practice to optimize care of stroke survivors. To get started, you'll need to register yourself online at the COMPASS website. Be looking for your individualized care plans on each of your stroke patients. And remember that all of your stroke referrals from referring hospitals that are participating in this initiative should be treating using the optimized COMPASS model of care. Always strive to keep your treatments consistently focused on structured and progressive care to optimize your patient's recovery. Everyone needs to be focused on educating clients on the 4 directions of the COMPASS and working to foster better self-management on the part of the patients. Consistent team communication among each other and consistent messaging to the patient and caregiver are keys to success. Finally, remember that we want to provide optimal care to the patient in every setting, and that means helping shepherd the patient and the family to the next level of care. Thanks for your time and attention today. We look forward to a successful partnership with your team in helping our patients along the road to recovery.